Hey, today on Injury Territory, I am so excited. I teased this earlier in the week, but we're going to talk with one of the top sports medicine doctors in the world, Dr. Jeffrey Dugas from Andrews Sports Medicine. He's one of the ones really pushing forward the internal brace, the UCL repair. He's done so much research, so much work. I think you're going to be really interested. That's today. We're also going to take a look at a couple injuries here on Injury Territory. Hey, I'm Will Carroll. This is Injury Territory. And let's talk about a couple injuries quickly before we get to that interview with Dr. Jeffrey Dugas. Number of them. The first one let's talk about is Juan Soto. He came out of Thursday's game with a calf strain. He's headed for an MRI on Friday, or excuse me, did that on Friday night. He'll have the MRI on Saturday morning. Schedules don't matter much when it comes to a player like that. So they'll open up the MRI clinic. They'll get him in there, see how significant this is. Doesn't look good. At this point, it would surprise me if he doesn't head to the 10-day IL just as a precaution, but the MRI will be the guide here. A couple rehabs that are ongoing. Zach Wheeler had his second outing. Didn't go as well as the first. Didn't have any injuries, made all his pitches, just weren't as effective for whatever reason. So he's likely to make one more. That was the plan. There's questions if he just dominated again, that he might come up and throw in a short, but it looks like Wheeler will be going again. One that was supposed to go on Friday night, Trey Yesavage. Unfortunately, rain. Nothing wrong with Yesavage. I am assuming he is going to go on Saturday night. But was rained out with the Buffalo Bison. So that's going to continue on. The Cubs, Cade Horton came out. He has a forearm issue. The assumption is a flexor strain. They're going to have MRIs. We'll see exactly where that goes. But it looks like he's headed for the IL. Could be an extended absence, which puts pressure on a Cubs rotation, which isn't super deep. They've got some young kids who are further down. You know, a lot of times you take a look and you're like, who's at AAA? Is it a depth guy or is it a guy who could actually be a competitive part of the pitcher or a guy who's just going to give you innings? And they have far too many of those guys who are just going to give them innings. We'll see how the Cubs deal with that, how serious it is for Horton. We should have news on that by Monday. Last one I want to talk about is Zach Eflin. He is headed for a second opinion. This is common. People hear second opinion and think like he didn't agree. That's not usually the case. He's going to see Dr. Keith Meister, who you'll see referenced in the interview here in just a few minutes. But Eflin likely to need UCL repair or UCL reconstruction, some sort of some variant of what we call Tommy John surgery. So it looks like his season is done. These are normally 12 to 14 month rehabs. We'll see where that goes. It's unfortunate. Last one I want to talk about, and this one's too simple. Jordan Lawler, the shortstop / outfielder for the Arizona Diamondbacks, took a ball off his hand and has a fractured hand. Again, I have pounded the table over and over for padded gloves. This is one that likely could have stopped or at least reduced the injury. We see a number of players that are doing this. It goes as far back as Jeff Bagwell. It's the first one I remember after he had broken his hand a couple times. But if Shohei Ohtani can do it, if he can wear a padded glove and still do all the things he does, why doesn't everybody else, especially at the youth level? I had a parent this week that called me saying, hey, my son got hit on the hand. Who should he go see? And you know, those are fairly simple and unfortunate because injuries that can be prevented are, to me, the worst ones. So, like I said, I am so excited to have Dr. Jeffrey Dugas coming on. Super excited to get him, any of these top doctors, and we'll have more of them in the upcoming weeks. We've already had Dr. Chad Lavender. We're going to have more athletic trainers. We're going to have more scientists like Dr. Tyler White. So sports scientists, I should say. So we're going to take a quick break. And when we come back, that interview with Dr. Jeffrey Dugas. Hey, welcome back to Injury Territory. I'm Will Carroll, and I'm about to talk with Dr. Jeffrey Dugas. You've probably heard this name in association with elbows, but he does shoulders, he does knees. He's been published on everything from internal braces in the elbow to cartilage in the knee. He is one of the top doctors around in sports. He was educated at Duke. He did his fellowship at the American Sports Medicine Institute in Birmingham under the direction of Dr. James Andrews. You'll hear him reference several doctors, the top guys around. A lot of them came through there. He's the medical director for USA Cheer. He's the co-medical director for the WWE. He does a number of colleges. He's the sports medicine doctor for the Birmingham Barons, which is the AA affiliate of the Chicago White Sox, and the Alabama Ballet. I didn't ask about the ballet or the WWE, but they're kind of the same thing, aren't they? Anyway, here is my conversation with Dr. Jeffrey Dugas. Dr. Dugas, you came up at a time when Tommy John was basically considered perfect. We know there's always been something of a failure rate with it, that not everybody comes back for one reason or the other. But what really drew you to internal brace? It was new at that stage. Nobody had really tried it on the elbow. What was kind of the genesis of this revolution?
It was actually, well, first, let me say thanks for having me, Will. It's always good to talk to you, but I
It's an honor.
appreciate the opportunity. It was more of a clinical thing. We did a lot of these cases with Dr. Andrews, Lyle Kane, and myself, and we found that we had one hammer for every nail, and it didn't matter how bad the injury was, how much torn it was, whether it was completely torn, partially torn. I mean, we were doing the same operation. And I remember Dr. Andrews saying to us a couple of times, like, it's a shame we have to do this big operation on this kid with just this little bit of injury, and you guys got to come up with a better solution. So it was really him pushing us to think, how can we manage this without doing, full reconstruction on these people? And so that was the genesis of it. And it turned out that Buddy Savoy had done some work and published in AJSM in the mid 2000s, 2006 and 2008 on direct repair of avulsed ligaments, first in female athletes in '06 and then in overhead athletes, mostly male baseball players. I think the average age was 18 or so. So these were high school and college kids mostly, and the success rate was like 95%. Getting them back to the same or higher level at 6 months, so half the recovery time. But people didn't really pay attention. I mean, that didn't really change anything. And Buddy's, one of the best ever. So the internal brace had come out, and a guy named Gordon Mackay, who's a foot and ankle surgeon in Scotland, had been the first one to do it and kind of popularized it. For a year or two, he'd been talking about it, and I reached out to him and asked for, we talked. I talked to him about his experience with it, how he got there, what he was doing with it, what he's seen, what the complications were, what the issues were, if there were any. And I thought we could probably do this in the elbow. So I reached out to the company and I said, hey, I think this is a good spot for this. And they were unsure and they didn't think it was big enough. And, the anchors were too small. And I said, no, I think this will work. And so I went down to the company and they pulled out a couple of cadaver specimens and we did some basic science testing on it. And sure enough, it worked. And we did some studies with it that they funded to make sure it would hold up to the strain we were putting on it, based on the current gold standard of reconstruction. And it was at least as good. The point was not that it was going to be better, but we wanted it to be at least as strong before we put it in a human. And that worked out. And then we did the first case in August of 2013.
Now, we always talk about Tommy John surgery because that was Frank Job's first patient. Do you remember the name of the first patient? Can you say it out loud?
Yeah, he's given me permission to do that. His name is Mark Rogers. So I told him we ought to call this the Mark Rogers procedure, and he said absolutely not. He was a kid in high school. He was a lefty pitcher. He was a senior, rising senior, and he was a pitcher only, and he wasn't going to be able to do it. He had a collegiate ability, and so we did it. And he pitched his whole senior season. Started like 5.5 months post op, and went. I think he was 9-1 his senior year, and he wound up getting a junior college deal. He's now a firefighter in the Dothan area, and great guy. I still communicate with him occasionally, and just a wonderfully good guy.
That's a great story. Now, obviously, this came about because of two techniques: the repair and the internal brace being invented. Makai, you mentioned popularizing it. How much is the tools and the materials? How much is the repair, or did you have to have them both at the same time for this to work?
I felt like we had to have both because, we kind of said this is going to be good for a certain number of these things. I remember when we went down to the company and showed it to them that we could do this, they said, "Oh my gosh, this is going to replace, Tommy John surgery." I said, "No, no, 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 no. This is going to be good for some." So I still say it this way, reconstruction fits all. Repair with internal brace fits some. And that was never, the point was never that this was going to replace anything or be better than it. It didn't have anything to do with whether a major leaguer ever had it done or anything like that. The point was we think that doing one operation for every pathology just didn't make sense, and it doesn't. And so doing the repairing some of these end avulsions, I think, is important. And that's been borne out in the revisions that we've seen too, when the reconstructions tear off the bone. So repairing the tissue back is important, and then augmenting it with the internal brace is really what you're doing.
Now, obviously, some of this hinges on selection. So when you're looking at an elbow, when you're examining the person, seeing the MRI, or even when you've opened them up, what tells you this is a repair versus this is a Tommy John?
That's a great question, and we published this study last year, about a year ago, in AJSM. I think we had 400 in each group of repair with internal brace and reconstruction, and the statistics were essentially identical in terms of rate of return to play at the same or higher level, complications, reoperations. All these things were basically identical between the groups. And people say, "Oh, it's why would you not want to do an internal brace? It's the same. It's just as good. Do that every time." And I said, "You're missing the point of the study. The point of the study was we're doing a good job of deciding who is best for each operation. That's really the take home message of that study is, yeah, they're both good, but you have to select them properly." Exactly to your question. So to me, there are really three criteria to do the internal brace. And like I said, full reconstruction fits all. But I think there are three criteria. Number one, you have to have an end avulsion. So the injury has to be at the end of the ligament, not in the middle. I don't think that in large scale, doing these for mid-substance ruptures is going to be as good as doing the ones that are end avulsions. Have we done a few? Yeah. Have they worked out so far? But I think that over large scale, that's not going to be as good. So end avulsion. Number two, you have to have good tissue. So repairing beat up, crappy tissue is not a good thing anywhere in the body. And so having decent enough tissue to repair makes a difference. And so the way I say that is there can't be a tissue deficiency. So you have people that have bony ossicles in their ligament and heterotopic bone in their ligament. When you have to take that out, you have a tissue deficiency in the ligament. That's not going to be okay to replace with the synthetic tape. You have to add collagen, and they need a graft. So I think the quality and quantity of the tissue is the second criteria. And I think the third criteria is you should have a benefit from a shorter recovery. And it may seem like, well, doesn't everybody have a benefit from a shorter recovery? And the answer is no, not really. When you get to certain levels of baseball, especially at the professional level, seasonality really plays a role. And so in people, for instance, that we've seen over the last couple of months, December through October through now, or October through March, if it takes them 12 to 14 months to get back at the professional level, that's okay because they have such a long season that they're not really going to miss the season. Whereas a high school or a college pitcher, they don't have that luxury. And even some of the pros don't have that luxury. Some of them are in contract years, or they're going to be free agents, or for whatever reason, they don't have that luxury. So I've had some professionals that have said, look, decide based on the tissue and what you see. Don't worry about the timeline. And I'm fine with that. If they want me to make that decision, I can. I think we get imaging on all these things. Everybody has an MRI. And so I think the preoperative MRIs are probably in the 90% range in terms of giving us the ability to predict, or is this going to be amenable to one or the other? So I would say about 90% of the time we're pretty accurate at gauging that. But there are times where we change our plan based on what we actually see and feel when we're in there, and that's just the limitation of MRIs.
Of course. Now, obviously, Dr. Dugas, the internal brace gets guys back faster, but too many times, especially at the professional level, we're seeing it's the rehab that goes longer. Is this, how much is biological healing guiding this, and how much is just pure risk aversion? Because a guy who's taking 18 months to come back from an internal brace, that shouldn't be the case.
I haven't seen that. Yeah, I haven't really seen that happen in the longer rehabs. The rehabs have been shorter. I'm not aware of the people taking longer. At the pro level, a lot of times their seasonality gauges it.
Yeah.
And or where they are. But I haven't seen longer recoveries in the revisions. We're typically seeing 9 months as opposed to 18 months with revisions. With the primaries, I'm seeing 6 to 8 months depending on position and grade of injury. I'm not seeing prolonged recoveries from the internal braces. Now, there are people that are having hybrids where they're doing both.
Right.
And I think that's important to put in here. And Keith and Chris and others that have popularized this. The problem with the hybrids, one of the issues with the hybrids is everybody has a different brand of hybrid, and people, there's probably 20 different versions of it. And so it's hard to know what is working and what's not. And just so the people listening, hybrid is basically you're doing both a reconstruction and you're adding some synthetic repair, internal brace, something like that. But there are multiple forms of that. I think that the rehab of that still has to allow the graft, the tendon graft, to incorporate into the bone tunnels and become ligament. And that takes 12 months. And so I don't think at the highest levels of baseball, there's been a real change in the rehab of the hybrids. They haven't shortened the rehab time, the comeback time. And I think it's because you're still having to incorporate that graft tissue. And the postulate of the hybrids among us who do them is, will this decrease the revision rate? Will the reconstruction hold up longer because we're adding another thing in there to support it? It's not, I don't think anybody thought the hybrid was going to be a get back faster experience. I think we were hoping it would be a last longer experience than just reconstruction alone.
That makes sense. Just so everybody's clear, Dr. Dugas, when he says Keith and Chris, that's Dr. Keith Meister and Dr. Chris Ahmad, I am guessing.
Correct. Yes, correct.
Great. Now, obviously, going back to that first one, you've done a lot of high school guys, obviously a lot of college guys in your work, as well as professional, but we're seeing younger and younger patients. Is that because we're actually seeing more failures, or because the environment around the pitchers has changed in a way that's exposing those weaknesses earlier?
Well, I think we're seeing, the infatuation with velocity and spin rate is not going away, and we're seeing younger and younger people throwing harder, longer. I operated on a high round, I think first or second round draft pick last week, who's 17 and throws 102. And, I mean, that's the body at that age is not ready for that. The ability to generate enough torque to throw a ball really hard is a great thing, and it's intoxicating almost for everybody involved, for the player, the parents, the coaches, the teams, the other parents and coaches, the other players. I mean, it's great, but that doesn't mean that the body is ready for that kind of torque and power to go through the tissues of the arm. And how long they're throwing. Are they doing a long season? Are they, what other things are they doing? I still say that the professional teams, they know that the tight shoulder is the death of the elbow. And so it's rare to see a professional with a tight shoulder. And that's because they check it all the time. They have enough staff and athletic trainers to check it. You rarely, if ever, will see a pro with a tight shoulder. But I would think that if you followed me around, probably 90% of the high school and college kids that I end up operating on for this operation have a tight shoulder. They've lost rotation in their shoulder. And that is putting a lot of force and torque on their elbow. So all that energy is still going to the ball. So it has to travel through the elbow. And so there's a lot of energy going through that tissue, and that's where these injuries occur. So I think if I was going to impart one piece of advice to anybody listening, it would be never lose range of motion in the shoulder. And if you look at major league teams that are averaging, somewhere in the neighborhood of 1.5 Tommy John injuries per club per year at the highest level of baseball, that's probably the floor of what we can expect at that level. And trying to decrease it from there would be a little bit like eliminating concussions from football. It's football. You're not going to get rid of concussions unless you change the sport. So unless we put a cap on throwing in baseball, I don't think we're ever going to see that go down at the major league level with a 162 game season and these elite athletes throwing the way they throw. So to have only 1.5 per team, I think is probably that's going to be the best we can do. And so why are we seeing 3 and 4 per team in college and 3 and 4, high school? And it's just crazy how much more we see on some of these teams at lower levels. So I think that's the thing that if I could impart one piece of wisdom to coaches and parents and kids is you have got to learn how to stretch your shoulder and know when it's ready to throw.
I agree. I think any parent or coach out there should have an athletic trainer, a physical therapist, even a sports medicine physician check that fairly regularly and learn how to check that. I think that's absolutely a key. Now, obviously, you've been the center of this shift. We've seen rehabs at most levels with this go down. As you're looking at the game right now, and overall picture, not just pro, what does baseball still not understand about the elbow? It's a relatively simple joint, and yet it seems like we're discovering new things all the time.
Yeah, I think we're seeing baseball continues to evolve. It was interesting. I guess it was 2 years ago when the ball changed and they took some tack off the ball, and that obviously disadvantages the pitchers, and so that's when we start seeing these sweepers. So with the advent of the tack off the ball, we saw the advent of the sweeper pitches. The pitchers are not going to just go gently and say, oh, well, I guess we're going to have, balls are going to be sailing out of the yard, all the time because we took tack off the ball. The pitchers are going to respond just like the hitters are going to respond if you advantage the pitchers. So there's always going to be a give and a take on these things. So I don't villainize baseball for making the decisions they make. There's going to be a give and a take. So I think on the front of what we've seen a lot more of what we're kind of calling designer pitches I think I was watching a game the other night and somebody said Max Fried throws 7 pitches. That's great. So there's all these different types of pitches that are being thrown. These sweepers are putting a lot of spin on the ball. So we're seeing differences in grip, differences in spin. We're seeing changes in delivery. So these are things that the pitchers are responding to the needs of what the ball and other things have dictated, the pitch clocks and things like that. So, I think the sport is healthy. I think from an elbow and shoulder perspective, I still would rather have an elbow problem than a shoulder problem every day. And, I think if we have to look at the bright side, at least we're not seeing an uptick in shoulder injuries. But, the elbow stuff is real, and it's real even more so at the lower levels. And, I think that we're throwing too much at the youth levels. I think we're throwing too many pitches. I had a kid in my office this week who's a high school kid who threw 130 pitches, and it was the first week of April, last week of March, and that's criminal. And you won't see a major league pitcher throw 130 pitches this whole season. And these guys are grown adults, and we have a 17-year-old throwing 130 pitches. You can't make sense of that in any form.
Yeah, it's crazy. Now let's tell people about something that maybe they don't know, because they do know that you spend your days repairing elbows and shoulders and knees and everything else. But then you go and run a distillery of all things. Now, Tread River, that straight bourbon is straight fire. It feels like the opposite pace. It's slow, it's deliberate. You can't just make an aged bourbon overnight the way you can fix an elbow. So, what carries over? What has making whiskey and other distilled products mirror what you do or taught you about being a doctor?
Well, I don't make it first. I don't run it. I don't make it. I started it, and I brought in people that are really smart. So I have a chemical engineering degree, and Lyle and I both do. And chemical engineering, I never wanted. Yeah, Lyle Kane. I never wanted to be a chemical engineer, not one day. But somebody told me if I could do this, if I could do well at this, all doors would be open to me, and I could go do whatever I wanted. I wanted to go to medical school, so I took the advice and I worked hard at it, and it was hard. It was the hardest thing I ever did. I don't think I could ever do that again. But chemical engineering is really process engineering, and so the process of making decisions, the process of solving problems. And people ask me, all the time what I think I'm best at, and they expect me to say something orthopedic. And my answer is always, if I had to be complimentary of myself, which I struggle with, I would say that I'm an elite problem solver. And I think that's really the engineering background. So part of chemical engineering is distillation and fermentation and all these kind of things. And so when I was in college, I wanted to learn how to brew beer. So brewing beer was a hobby for 25 years. And you go to enough breweries and distilleries, and this guy in South Carolina said, Birmingham is the largest city in North America without a commercial distillery. And I thought that can't be true. So I looked into it, and it was true. And I got with the city and some people, and they got behind it. And next thing you know, we're taking a building and we're turning it into a distillery. And so we bought the best equipment money can buy. I said, if we're going to do this, anything that we do as members of the practice, any of the members or partners in the Andrews, anything we do has an impact in the brand. And so we got to be very careful not to do something that doesn't meet the brand standard. And the Andrews brand is really good. So we have to be careful with that. So I said, look, if we're going to do this stuff better be good. Like, this is not a novelty. We can't be making, stuff that is people are going to laugh at. This better be really good stuff. So we bought the best equipment we could get, and we hired really smart people. We get really good heirloom grain. And there's two things about Alabama that make making booze really good. Number one is the water here. So the water in Birmingham has more limestone in it than Bourbon County, Kentucky. So there's a lot of ore and mineral under Birmingham, and these cisterns and things that the water comes through and filters the water. So the water quality is really excellent, which makes a huge difference for making spirits. And the second thing is the amount of heat we have here. So as opposed to beer and wine that don't like heat, aging spirits love heat. We have lots of it. So we get a little bit faster age here because of the amount of heat and humidity we have. And that makes a difference. So we have a lot more heat and really good water. And you mix that with the quality of the people we have and the equipment and the grain and everything, and you make some pretty good booze. And it takes time. It's definitely a patience thing. But we're now going on 7 years, coming up on 7 years we've been in business. And so our oldest bourbon is about to hit 7. It's drinking more like a 9 to 10 year bourbon. And we've won a couple of really nice awards. There's another one in about 2 weeks from now. We're getting a pretty good one that I can't disclose, but there's going to be some new news on Dread River coming out later in April.
Exciting. We'll have the link down in the description. Something you said there reminded me. I was going to close with that question, but it just struck me with the problem solving. I remember I had the honor of interviewing Dr. Frank Jobe just before he passed, and he was talking about his first Tommy John. He was standing there with the other doctors looking down, and he said he just looked down at the elbow and paused. And he was like, what do I do now? I have ideas, but he didn't have a full plan. So that elite problem solving immediately made me think that. Final question for you, and this is another one that just occurred to me. A lot of people will call me and say, "Hey, I've got an athlete who I think is going to need Tommy John, or my son, somebody needs to look at his elbow." They never think they can go to the elite doctors. I always find out where they are, who it is. If someone has that problem, could they come to Andrews Sports Medicine? Is it impossible to get in? Is it just pro athletes do you have? Which I know isn't true. That's a terrible question. But how could somebody actually come down and see you?
Well, I appreciate the question, and us, we're very humble. Anybody can come see us. We say yes to everybody. So it's not hard at all. If you email us at Dugas at andrewssm.com, DUGAS at andrewssm.com. We will make it happen. So we make it happen. Typically, people can get in within a week. We try to accommodate people. We understand that there's anxiety and people need to get back to their things. So I've always defined sports medicine as I don't have time for this, whatever this is. If I get up from this chair and twist my ankle, I don't have time for that. I need to get past it because I got things to do. So we have to kind of respond in that way to our patients, whether they wear a number on their back or not. And most of them don't. Most of our patients are just regular people, and they just have active lives, and they don't have time for this. And I think that's really the way we have to respond. And our entire practice is set up that way. We have 25 of us that respond that way. And so we'll make it happen. If you just email us, we'll make it happen.
Hey, that was Dr. Jeffrey Dugas of Andrews Sports Medicine, flat out giving out his email in case anybody needs their elbow checked. Great stuff down there. And again, Dread River, his distillery, very top-notch stuff. And I don't say that about just anything. I think it very favorably compares to some of the younger Texas whiskeys. I do think it ages more because of the heat, and the heat changes. But he's a chemical engineer. Not me. I just drink it. Again, thanks so much to Dr. Dugas for taking the time out of his busy schedule on both the distillery and the doctor side. Thanks to you for subscribing, for sharing this with your friends, for all the feedback and comments. Thanks to everybody at the Foul Territory Network. We'll be back next time because the injuries never sleep.